Well, welcome back for the afternoon session. I'm very pleased to welcome Russell Lewis, who's being wired for sound now. He initially got a doctorate in pharmacy in the University of Kansas and then went on to do residency training at the Barnes Jewish Hospital in St. Louis, Missouri, and then did a fellowship in infectious diseases in Iowa. He now works at the MD Anderson Cancer Center and has been working there for 11 years, and he does research on antifungal pharmacology and does consults within an infectious diseases service. Thank you very much indeed.
Thank you. And thank you on the web for turning in. My job is to talk about steroids, Aspergillus, and antifungals, and specifically how do these three interact in the body, especially drug therapy, because we know many of the drugs used to treat Aspergillus and some of our immunosuppressive therapy have interactions, and I'm trying to, I guess, just provide the background of why do these drugs actually interact in the body. So what we're going to focus on is really three issues. How do steroids and antifungals act on your body? That's the pharmacology aspect. How does your body act on these drugs? That's pharmacokinetics, meaning how do we metabolize and eliminate these drugs? What are the benefits and risks of using a steroid inhaler, for example, with itraconazole, or using these separately? And is there a possibility that steroids or some of these medications will directly influence Aspergillus and its biology in the host? Now, what's interesting is when I sort of step back as a day-to-day clinician, I think about drug interactions all the time, but I don't always think about the biological basis of why there might be interactions. And it's sort of interesting when you think about historically and years of evolution that Aspergillus and humans share many of the same enzymes for not only synthesizing key components of their cell membrane, which, as we heard, in fungi, ergosterol's the key membrane sterol. In humans, it's cholesterol. And this difference is very, very important for antifungal medications because by specifically targeting ergosterol, we can spare the humans somewhat, although not entirely. These humans and Aspergillus also share many pathways specifically for synthesis of steroids in the body. So there's sex steroids like testosterone, estrogen. There's mineral corticoids that are used to regulate salt and water balance in our body. We also have glucocorticoids that play a very important role in inflammation, and these are the ones that we are often most concerned about with Aspergillus. Interestingly, we also use many of the same enzymes or pathways to metabolize drugs, to make the drugs more soluble so we can excrete them. So if you think about a patient who has Aspergillus and we're using a drug to target Aspergillus, and then we're giving the patient steroids, there's a potential for all of these drugs to interact. And this is just sort of kind of overlaying the pathways of how these sterols are produced, and what you'll see is that there's, at some point, they don't completely overlap, but there's this divergence where in Aspergillus, ergosterol is important, in humans, cholesterol. But cholesterol is a key building block of many of these steroid hormones that we're going to see in patients, and they play a role in inflammation and dialing down inflammation. And what's interesting is that, for example, some of our anti-cholesterol medications actually have weak antifungal activity. Some of our antifungal agents will actually block the steroid synthesis in the body. One of our older antifungals, ketoconazole, would actually block the production of testosterone. So patients on high-dose ketoconazole, males, for example, would begin to develop breasts and things like that. So the point here is that drugs designed to target one of these pathways have the potential to affect multiple pathways, and that's why we worry about these drug interactions. Now, in the case of steroids, a lot of times when you say steroids to a patient, they think we're talking about like testosterone and bodybuilders and things like that. But in the case of aspergillosis and anti-inflammatory effects, we've focused predominantly on glucocorticoids, which have a different role in the body than the sex steroids. The sex steroids are anabolic, they build up. Glucocorticoids are more important for inducing breakdown with glucose and suppressing the immune system. So they play a different role biologically. They're important for sort of fight or flight and responding to stress. So glucocorticoids, the one that's produced naturally in our body endogenously is cortisol. And this is it plays a very important role in regulating a number of cardiovascular, metabolic, and immunological functions. It's part of our key response to stress, so people who don't produce enough cortisol naturally will not do very well, for example, after surgery or after trauma. And it's a very important part of the feedback mechanism of the immune system. It's what helps dial it down and dials down inflammation. So when it was recognized that we could synthesize synthetic versions of cortisol, and this was done in the 50s, this could be very useful drugs in patients who have a disease where there's too much inflammation. So a drug like prednisone can be prescribed to suppress a damaging immune response. Now, as we heard in a case like asthma or allergic bronchopulmonary aspergillosis, a drug like prednisone can be very, very useful because we know this disease is characterized by the fact that your airways with constant inflammation will begin to thicken and narrow and become stiff, and they'll become clogged and plugged up, so you will not be able to exchange air as well. And if this progresses long enough, these changes may not be reversible, and then we have to start talking about things like lung transplantation or more other serious approaches. So if we can intervene early with a drug like prednisone, we can suppress this inflammation, suppress this inflammatory remodeling, and maintain some semblance of a normal airway, hopefully. And then over time, perhaps with antifungals, with less exposure to Aspergillus in the air, the patient may be able to come off these medications and do quite well. So this is an example how steroids play a very important role in the management of Aspergillosis, Aspergillus-associated allergic bronchopulmonary aspergillosis. Now, why not just put somebody on a steroid and leave them on a steroid for a long time? Well, the problem is the receptors that the glucocorticoids act on are found throughout the body. And if you were to look at the list of potential side effects with glucocorticoids, we've heard this mentioned, but this is why it's a very important point in thinking about when you're going to start a patient on glucocorticoids, what am I gaining in terms of the benefit versus the risks? And the potential risks are that your ability to endogenously synthesize your own glucocorticoid, cortisol, is maintained by a very important thermostat they call the HPA axis because it has to do with feedback of cortisol and the concentrations you produce. You produce more cortisol in the morning, it declines over in the evening. And so when you give somebody exogenous corticosteroids, prednisone, in high doses, over time, you'll actually suppress this axis. And if you pull somebody off the drugs quickly without tapering, without using progressively lower doses, then you can actually have an adrenal crisis where the person's not making enough cortisol to basically support their basic life functions. The other things that we worry about, muscle weakness, diabetes mellitus, because they affect gluconeogenesis and glucose production, you can have a patient who has persistently high blood sugars. This can be immunosuppressive in and of itself, but it can also lead to complications. Cardiovascular complications, including hypertension, high blood lipids, arteriosclerosis, glaucoma, cataracts. We also know that people who take high doses of corticosteroids sometimes have euphoria, sometimes they have strange dreams, sometimes they may feel depressed, and there's even rare cases where you can see psychoses. Glucocorticoids, they cause thinning skin, they cause redistribution of fat, they also cause, in some patients, decreased bone density, including osteoporosis and necrosis. And, as we've heard, they're also immunosuppressive. So just starting a corticosteroid and leaving the patient on it for a prolonged period, the problem is, over time, you're going to be at increased risk for these side effects. So we really try to limit that. Now, in terms of the infection risk, this is something that always comes up. What specifically is the infection risk with a corticosteroid, like taking prednisone for long periods of time? Well, the term that's often used by clinicians is the patient will develop suppressed cell-mediated immunity, meaning Their neutrophils, their monocytes and macrophages will not be able to phagocytize or eat bacteria as well, will not be able to attack and eat fungi as well. They also will not be able to communicate as well with the T lymphocytes, which are the key elements of the immune system in terms of orchestrating the response. So the problem is that you will not be able to fight off infections as well with some bacteria and fungi, and even viruses. The other problem is that glucocorticoids can mask the symptoms of infection. It may mask your fever. It may mask symptoms of inflammation. So you can develop a very severe infection with virtually no symptoms. And this is something that's very, very important to communicate to a doctor or healthcare practitioner if you are taking corticosteroids, that you are on these drugs, so they know to look very carefully for infection even when the typical symptoms are not there. One of the key questions is then, how much in terms of dose of corticosteroids would you have to receive to develop severe Aspergillus infection or an invasive Aspergillus infection? And there have been some studies that have looked at this in high-risk patient groups, allogeneic bone marrow transplant patients, meaning they got bone marrow from another donor. And what was found is that patients who were getting greater than 7 milligrams per kilogram per week of, in this case, methylprednisolone, were at much higher risk for developing the infection. And then this is a very high-risk subgroup where the patients also have graft versus host disease. So we really try to limit the amount of corticosteroids. They really are wonder drugs, almost sort of, I think many people would say, as important as penicillin in modern medicine. But they do have side effects that accumulate, and we try to reduce those risks. Now, one of the ways that we can reduce the risk of a problem with glucocorticoid therapy is to try to administer it in the cases the problem is inflammation in the lungs, is to directly administer the drugs to the lung with an inhaler. And the advantage of this is only about 10 to 20% of the dose is going to be delivered to the lungs. This is going to reduce non-specific interactions with those other organs and those other side effects. You will swallow some of the drug. When you shoot the inhaler, it hits the back of your throat. You will swallow some of it. That can be improved somewhat with spacers and different types of masks. But once you swallow the drug, it is metabolized in the lining of the gastrointestinal tract and also the liver. Now, what's interesting is the side effects that tend to occur with inhalers tend to be with the drugs that you actually swallow. So there's been a lot of interest in the development of new inhaled steroids to make them less absorbable and to also make them so they will not make it into the systemic circulation, the bloodstream, where they'll interact. So I think the good news is many of our inhaled steroids are much safer now. And if you look at all those side effects I mentioned, they're much less likely to occur with an inhaled aerosolized agent. So the key point here is that synthetic glucocorticoids are often the most effective therapy we have for preserving lung function in patients who have diseases that have an allergic or inflammatory component with Aspergillus, but their long-term use can be associated with side effects, including severe infections. Therefore, our goal is to use the minimally effective dose, either orally or inhaled, that provides benefit. And this is why there's always this approach towards reducing doses and looking to see if the disease is exacerbated. Now, let's just briefly talk about how your body actually acts on medications. Some medications can be excreted in the stool without modification. Some drugs are very water soluble and they can be filtered by the kidneys and passed in the urine without significant modification. But many drugs, including antifungals, need to be modified by your liver before they can be excreted. And this is done primarily by two major pathways. And the problem that we run into, especially with antifungals, is that if you're taking a second drug that uses the same pathway or enzyme system for excretion, then you can develop a drug interaction. You'll have much higher exposures to one of the drugs than initially anticipated. So we have to be very careful with antifungals, particularly antifungals that are typically used when you're outside the hospital that can be taken by mouth. The azole antifungals, itraconazole, voriconazole, and posaconazole all have a very high risk relative to some of our other drugs for drug interactions. So we have to be very careful about this. Now, why do they have this high risk of drug interactions? Well, the way azole antifungals act is they inhibit a cytochrome P450-dependent enzyme in fungi that's responsible for making that membrane sterol ergosterol. This enzyme is very similar to an enzyme that humans use to metabolize drugs. So by virtue of the fact of how these drugs actually act in fungi, they also inhibit some key important enzymes in humans that are important for metabolizing drug therapy. So there's some differences among the azoles. Fluconazole is a drug that's not used for Aspergillus because it's not as potent, and it's actually more water soluble, and it doesn't bind to this enzyme as tightly, so it doesn't have the same number of drug interactions. But the drugs that we do use for Aspergillus, voriconazole, itraconazole, occasionally posaconazole, do have a potential for these drug interactions. So it's very important that if you're taking these medications, that you do inform your healthcare providers you're taking these medications, especially if they're going to start you on a second drug. Some cases, we anticipate these drug interactions and we can make adjustments. And in the case of allergic bronchopulmonary aspergillosis, one of the interactions we're concerned with is the oral azole antifungal and an inhaled corticosteroid, because essentially, if you're taking high doses of synthetic steroids for prolonged periods, this can suppress not only the body's cortisol set point, but if you add a second drug like voriconazole or itraconazole, this will also decrease the metabolism or clearance of the sterol. So now you're taking an even higher dose than previously anticipated, and this can really suppress your cortisol thermostat. And some people will actually develop symptoms of this. They'll begin gaining weight, they'll have high blood pressure, they'll have really high blood sugars. So this is something that needs to be monitored in many cases. Not all patients will develop this interaction, but your doctor can lower your steroid dose and monitor your blood test to make sure that you do not develop a severe reaction. So the key point here is, if you're on an azole antifungal and steroids, you're at higher risk for drug-drug interactions, but we can anticipate these and we can reduce your risk by making adjustment of the doses to your other medications and with careful follow-up. It's important in terms of compliance, if you're taking these medications, that you take them exactly as prescribed and you don't change doses, or you don't double up on doses or withhold drugs or stop the drugs without telling the physician, because this can really change these problems in terms of troubleshooting if you do develop problems. And in some patients, I think the key point here is, there are interactions, but in some cases these interactions are good. By, in many cases, going on antifungal therapy, you can lessen your need for steroids, and this maybe can prevent some side effects down the line. And I'll just finish by saying something about steroids and aspergillosis. If you look at all these pathways and you see how they interact in mammalian cells and in Aspergillus, you might wonder, does Aspergillus recognize our own steroids in our body? If we give steroids outside of the effects on the immune system, does it directly affect the growth of Aspergillus? And interestingly, an analog of cortisol, hydrocortisone, actually has been shown to increase the relative growth of Aspergillus, at least in the test tube. And this might be significant. We don't entirely know. I think is that when somebody's on too high of doses of steroids for long periods of time, they may be at risk for more invasive infections with Aspergillus. So there are some risks, but I think there are also a lot of benefits with these medications, and that's why it's very important to communicate with the physicians taking care of you, and you can gain benefits from these medications. Thank you.
Very, very clear exposition. This paper is open for discussion now. Are there any questions? How do you then decide? We've heard about 4 kinds of aspergillosis in the first half of the session. And interestingly, I think the fungus is behaving differently in each of the 4 cases. And Marta said, well, obviously they use steroids as part of the chemotherapy regimes in, for example, managing leukemia. And then we want to put in the antifungals as well, because we know that we have to put them in early, and there's a sort of great anxiety, and there are other drugs to be considered. So how do we manage that? How does the clinician manage that?
Well, it can sometimes be, there's not a black and white answer, I think, to that. There are some drugs that we can anticipate there's going to be an interaction. And we have to ask the question, what is the severity of that interaction? For example, some of the immunosuppressants that are used after bone marrow transplantation or after a solid organ transplantation, they're very good because they can reduce our need to use steroids, but they have a sort of narrow therapeutic index, and we have to monitor blood levels.
Mm-hmm.
And we know that if you start an azole antifungal in patients on cyclosporin or on tacrolimus, you can see a 90% increase, in some cases more, of their blood levels, and that could put them into toxicity.
Yeah.
So there's some of these drugs that we have very good data, we can anticipate this, we can monitor blood levels and make decisions and follow the patient closely. Some of the interactions, especially with the steroids, are not as always clear-cut. You can read the textbooks and they'll tell you this one will increase by 30%, this will increase by 50%. I've seen cases where we shouldn't expect an interaction and the patient will have symptoms. And so I think it's that are consistent with Cushingoid or too much cortisol. So I think that we just have to anticipate this is a problem. If we monitor it and detect it early, we can make the adjustments and usually patients will do okay.
So it's monitoring, laboratory monitoring, which is key to the management of patients with complex drugs.
Yeah, and also I think just the clinical suspicion with the physician and good lines of communication and knowing that this is a potential side effect that we can see.
Right.
I'm aware of in studies with, for example, the inhalers and itraconazole, 50% of people will have suppression of their cortisol production. They'll also have much higher exposures to the inhalers. So there's now recommendations in asthma treatment guidelines as well as some of the other treatment guidelines for clinicians to use lower doses of the inhalers if they're on itraconazole. Right. And then you can titrate. You're always titrating these medicines.
There was a question submitted to the website which was about inhalers, and it sort of vaguely amusing, I think, to most clinicians, where it says in the product information sheet, which is often very, very long and very, very detailed, that you mustn't use the inhaled steroids if you've ever had tuberculosis. And of course, that's not something that I or any of my colleagues would particularly worry about, and yet it's there. And so she asked the question, is that correct? You know?
Well, you have to remember the labeling is written by lawyers and regulatory agencies, and I think that's an important thing to keep in mind, but we have to use clinical judgment, and any drug or any treatment has some risk, but for many patients who have this disease, there's going to be a lot of benefit of controlling that inflammation early so they don't have lung destruction, and they can do follow-up chest x-rays and make sure that there isn't a problem with TB and reactivation. So I think that we always weigh the risk versus benefits, and in most patients we can manage those risks very easily, and even very rare things like tuberculosis.
There is a question here. Thank you.
Another thought. We know from the toxicologic standpoint that different individuals, based on their genetic status, will have various SNPs that leave them without certain detoxification enzymes entirely. That can all be tested for now, and it would make sense to me, I think, to actually do that, because you can then find which patients are going to be at much, much greater risk, just as we've recently discovered with Coumadin therapy.
Yeah, I think that's the hope, that we'll have a pharmacogenomic approach where we can do that, and we're not quite there yet, but that's definitely the hope for the future, so we can personalize medicine.